Good morning, ladies and gentlemen. On behalf of FPD, it's my pleasure to invite you to participate today in the 1990 Colloquium. As you know, we're all facing this high pressure coming through from PEPFAR that in the focus districts we have to get to the 390s by 2017. And the purpose of today's meeting is really to tap the collective wisdom that exists amongst you as the PEPFAR implementation partners. So the way we're going to structure the day today is we're applying Chatham House rules. In other words, anything you say, you can speak freely. We are seeing this like a brainstorming session, and we need you to share with us your ideas. Doesn't matter how off the wall they are, that you think could help us reach these 1990s. Our structure today is each time we're going to have an introductory presentation just looking at the targets for South Africa and also the gap between the current reality and where we need to be within the next 2 to 3 years. Then we're going to have a subject matter expert who's going to give a 20-minute overview based on each of the 90s. What we've asked them to do is look at the literature and also tap into their own experience and give us a presentation. After that, we'll open up the floor for interaction with the audience. And we really want everybody at that point to contribute and to give us their best shot and share with us their experiences. Any advice you've got, any suggestions you've got is worthwhile that we put this into the outcome of this meeting. The outcome of the meeting will be in the format of as 2 deliverables. One is a video recording of today's session that we will make available on the FPD YouTube channel, and there will also be a written report that we hope to get to you within the next few weeks. Thank you very much for coming. I realize it's early in the morning to meet here in Midrand, and I hope that this is going to be a very productive session. At this point, I'm now going to hand over to Romy Overmeyer, who gives going to give the first presentation, just looking at the targets and what.
Good morning, everybody. My name is Romy Overmeyer, and I'm the HOD for Strategic Information at FPD. I've been at FPD for a year now, and my focus has been very much around all our targets and indicators and monitoring and evaluation processes. In the last 3 or 4 months, I've been working at the National Department of Health, supporting them on the 1990 initiative and with specific focus on the strategic information components. So what I'm going to do for you today is just give you a brief overview of 1990 and with particular focus on the South African context. 1990 being an international goal, South Africa has obviously tailored it for our specific conditions and for our specific treatment criteria. So as I said, we'll do a brief introduction to 1990 for South Africa. What does that mean for us as a country? Then look at some of the cascades that have been developed, and essentially the cascades are what drive a lot of the initiatives around 1990. It's also what we use to track progress for the different interventions. And then some conclusions based on the cascade analysis that we've done so far. So as I mentioned, 1990 is an international or global goal that has set targets around HIV treatment. In South Africa, we've adopted these further and applied them to TB as well, and various other programs. Essentially, it's been initiated through UNAIDS and means that 90% of all people living with HIV know their status, that 90% of those diagnosed with HIV infection are actually on sustained antiretroviral treatment, and that 90% of those on treatment will have viral suppression by the year 2020. In South Africa, as I mentioned, this is slightly different. In South Africa, because we have eligibility criteria in terms of our CD4 counts for patients, the 1990 is slightly different. So again, it does mean 90% of people living with HIV know their status. In South Africa, we're currently sitting at a figure of about 6.4 million living with HIV. That means that 5.7 million of those need to know their status by the year 2020. In South Africa, if we apply our eligibility criteria, it essentially translates to 4.1 million of those people actually being on antiretroviral treatment. In a little bit, I'll actually show you where we are today to show what the gap is between where we are now and where we need to be in 2020. And of course, in terms of virological suppression or viral suppression, we are looking at 90% of the 4.1 million being virologically suppressed, which translates to 3.7 million on sustained and successful antiretroviral treatment. Another thing that's happened that's actually driven a lot of the work around 1990 and also for South Africa introduced different interventions that may not necessarily directly relate to 1990 is the South African investment case. There was a big study done with various partners involved around essentially looking what gives South Africa the best value for money, what gives us the best bang for our buck, so to speak. It's about improving the allocative efficiency of the South African and TB programs, the South African HIV and TB programs, and really looks at what's the best mix of interventions to make sure that we not only achieve our targets, but achieve our targets in the most cost-effective way possible. The focus is very much on what we should do differently. In South Africa, we've had a fairly successful ramp up in terms of the HIV treatment program. We have one of the largest programs in the world, but we're getting to a point now where we really need to understand what works and what doesn't work on the ground. We need to understand our performance, and we really need to start focusing on doing things smarter, on spending our money smarter. This isn't a never-ending pot of money. And so at the end of the day, we are getting to the point where our resources are strained, and we need to make sure that we're using the money in the best way possible. So we need to do what works in the right places for the right people and where we know that we're going to achieve the greatest impact. So there's been a couple of things that have been focused on. Looking at the right places and the right people, we've looked at HIV burden across different populations, and what it essentially shows is that the focus should continue to be on urban settlements with particular focus on the informal sort of areas. Young women and adolescent girls also form part of the key populations that we need to be focused on, and initiatives like the DREAMS initiatives that's just been launched in South Africa is one of the interventions that we think will start making a true difference in this particular population. We need to focus on the major cities, simply because of the amount of movement in and out of cities and the large populations contained in our metros. This is where the highest burden of disease sits across the country. From an FPD perspective, we actually work in several of these metros, and other partners are allocated to the rest of them. We need to start focusing in these areas and making sure that the cities are also targeted in terms of HIV programs. So now looking very quickly at the cascades. In order to track performance, what a cascade essentially does is it represents a continuum of care, whether it be for HIV or PMTCT or the TB program. Within the 90 initiative, we've developed 6 cascades at the national level with actually 33 tracer indicators that essentially drive those particular cascades. The cascades, as I said, represent continuums of care, and they span across HIV treatment, PMTCT, pediatrics and adolescents, and TB. The cascades that have been agreed upon are the following. So we've got an adult HIV care and treatment cascade, which I'll show you, PMTCT. We have 2 pediatric cascades simply because the 2 different age groups get treated quite differently. So we have a pediatric cascade for under 5s, and then we have a children from 5 to 15 years cascade. There's also a drug-sensitive TB in the TB space. There's a drug-sensitive TB cascade, and then a drug-resistant TB treatment cascade as well. We're going to keep the focus today just on the HIV side, obviously, because this is focusing very much on the 90. Looking at the HIV cascade for South Africa, as I mentioned earlier, we sit with 6.4 million people on treatment. And if we look at kind of what that translates to in terms of targets, it will translate to about 2.9 million people being on ARVs by 2020. What the cascade essentially shows is quite interesting, because what you can see is where the biggest gaps are. So in terms of the number of people living with HIV and how many of those actually know their status, we're currently sitting on about 4.1 million. It is an estimate, it's based on certain calculations over the last year. So we're sitting on about 4.1 million people who know their status today. In 2020, the expectation is that we'd be sitting somewhere close to 5.8 million people. The red line is actually the target line for 2020. So as opposed to achieving our 90% target, or the first 90 as we all refer to it as, we're actually sitting at 64%. So you can see that there's a huge gap in terms of identification of adults living with HIV. The third pillar in the cascade actually represents a South African specific issue, and it relates to our eligibility criteria. If you look at the population that we estimate to be eligible today, we're sitting at about 3.2 or 3.3 million people, the target being 4.6. So there's quite a significant gap there, and it relates to the number that I identified with HIV to begin with. The interesting thing though is that if you look between this third pillar and the fourth pillar, you can see that of those that we've identified as eligible, we're actually initiating somewhere around 89% of them. So that's very close to the 90% target. So what it shows is that when we find people and identify the ones that need to be on treatment, to a large extent we are initiating them. So the second 90 for us is actually not the biggest concern. If you look to the third 90, however, there you can see a major drop-off. In South Africa, we have a little bit of a deceptive sort of reporting situation. If you look at virologically, or those that are virally suppressed, we're looking at a percentage of about 83% of those in the 12-month cohort that are virally suppressed. That seems like a good number, but the issue is actually that it's hugely underreported. So if you look at the percentage of people who are actually having their viral loads done, it's sitting somewhere around 46%. So that means, as opposed to looking at virally suppressed, virologically suppression rates for our total population, we're actually only looking at suppression rates for a very small proportion of our population that are on ARVs. The 46% is a huge issue and relates to several things. It is partially a sort of quality of care issue, and so we can assume that within the system there's a proportion of people who should be getting viral loads done who actually aren't getting their viral loads done, and obviously that's an issue from a patient treatment perspective. But the biggest issue actually, just from what we've seen in facilities that we've looked at, and this seems to be the consensus around the country, is that a lot of viral loads are being done within this cohort, but they're actually just not being recorded. So there is a very big data management issue that if we were to resolve it, would actually shift this number significantly in a very short space of time. In truth, the 83% is not something to be too surprised about. At the end of the day, we know treatment works. So all that tells us is that yes, if you put somebody on treatment and you retain them on treatment, their viral loads will go down. The issue is that at this point in time, we're not really sure that that's happening across our population because of this 46% and this huge gap in people that are actually not having their results recorded in the tier system. In terms of the PMTCT cascade, I think that largely what it shows, and I'm not going to go into too much detail about it, but largely what it shows is that the PMTCT program has been successful. We're sitting somewhere around a 1.4% transmission rate in those in babies who are HIV exposed. That's at 6 weeks, and a similar sort of number at the 18-month test as well. Moving forward, we are introducing as a country birth PCR and a 10-week PCR test, and we're expecting the numbers to be fairly similar. But the new indicators will allow us to create some more focus on this particular age group. I think for me what the PMTCT cascade shows though is that in a very short space of time, if you were to look at this cascade 10 years ago, it would have been a very, very different picture. We've introduced changes in our guidelines, we've intensified our focus around this program, and we've really shown significant improvement in a short space of time. So I think what it demonstrates is really kind of when you pick a few things to focus on and really do them well and put in the systems to support those things, that you can actually shift these numbers significantly in a short amount of time. So there's a drug-sensitive TB treatment cascade. Here you can see again, so in terms of the number of people identified with TB symptoms and those actually diagnosed, we're sitting at about 83%. So once you're identified with TB symptoms, you are generally getting a confirmed laboratory test. Once you are actually diagnosed with TB, we are generally starting you on drug-sensitive TB treatment. You can see that that percentage sits around 93%. The issue again is the successful treatment. So even though we're initiating people on treatment, only 77% of them are actually successfully treated in terms of TB. TB is a fairly intensive sort of program, daily medication, all that sort of thing, but 77% success rate is actually not nearly what we should be aiming for in this program. The drug-resistant TB, this one is a little bit more complicated because obviously just from a disease perspective, it is very difficult to successfully treat drug-resistant TB. So the MDR and the XDR treatment success rates are fairly low, and we will be pushing those up significantly in the next couple of years, working towards a 2020 target. Looking at pediatrics, I think there are limitations in the pediatric cascades for a couple of reasons. We have very limited data in the pediatric space. The number of indicators reported for pediatric HIV is very small. In fact, we only have under 15s tested and then under 15s initiated on ART and remaining on ART. So it poses a couple of problems. One, all our children are lumped together in one big age group, which makes it very difficult to understand what the true issues are and what the true gaps are that will vary significantly by age group. And also we actually don't know things like how many we're testing positive. We don't know much about what the retention rates are in this age group because the amount of data on the tier system is actually very limited. But if you look at the estimated sort of cascade, you can see that we're only identifying somewhere around 34% of the children living with HIV in the population. Now, I wouldn't necessarily place too much emphasis on this number and get hung up on the 34%. We've got new estimates that are going to be released fairly shortly from the spectrum model, which should give us a little bit more clarity around these numbers. But what it does show is that the number that I identified are very, very low compared to the number that are living with HIV. In terms of those initiated, we're sitting at about 80%. All of this is estimates, so again, let's not get hung up on the specific percentages, but if you look at it, that's fairly high. Again, it shows that where we find them, we are initiating them. The issue in the pediatric space largely is that we're not finding them. You see a similar picture if you look at the 5 to 14 years treatment cascade. So here, because of the eligibility criteria, you would actually have a third pillar in here around eligibility. Just because of the lack of data, I've assumed that all of these things are the same because we actually don't have an accurate way of splitting this up. But again, it shows you that we're only identifying somewhere around 40% of the children living with HIV in the country. This particular age group is even more difficult to target because, unlike the under 5s, this age group actually don't access the facilities. So as a country, we're going to have to start thinking very creatively about how we find them, where we find them, and how we test them, because there are all kinds of issues around consent, etc. So in terms of conclusions, I think the major issues that we've identified, and just looking at things across all of the 390s, is that in terms of the first 90, identification of people living with HIV in adults and children is an issue. Similarly, the issue exists with TB. We're not finding enough people. I think as we move towards 2020, as I mentioned, we've really done well in terms of the ramp up of ART initiation. But I think that as we move closer to a point of almost kind of saturation or hitting those 90/90 targets, and especially if we move to a universal test and treat scenario, it's going to be more and more difficult to find people living with HIV. The reason being, largely the people that we find today are the people who actually access the facilities. So the balance of the target is going to have to be hit by targeting people in their communities, by finding them outside of healthcare facilities and not waiting for them to actually come into facilities and access the services. The second 90, with current guidelines, we're initiating close to 90% of eligible people. Again, as we move towards test and treat, this gap will become more significant. We won't sit with kind of a population of essentially well people, even though they are HIV. They won't be coming to the facilities, and so we won't be able to initiate them. We'd have to go out and find them. And then looking at the third 90, I think this is the biggest issue. And if you look at the stats just on their own, as I indicated, you are looking at a viral suppression rate of 83%. But at the same time, this number is very misleading because half of the viral loads are not being captured. We're also looking at enormous loss to follow-up rates within the 12-month cohort. So we're sitting at about a 28% loss to follow-up rate in the 12-month cohort. That is significant. I think that there are several issues around this, though. I do think that there is an element of a data management issue, and particularly when you look at people who kind of transfer out and as opposed to being lost to follow-up, they're just accessing treatment in a different place. I think there are some gaps in the system at the moment that don't allow us to track people effectively. And talking about things like unique identifiers and systems is definitely somewhere we need to go in order to resolve this problem. But essentially, I would say as a priority, we really need to start thinking about how we identify those people living with HIV who do not access our facilities. And on the third 90, looking at how we make sure that the results that we are seeing at a clinic level actually get recorded in the systems and so get reported up.
Good morning. My name is Tato Farirai. I'm the HIV Counselling and Testing Specialist at FPD. Today I'll be presenting the first 90 of the 90/90 strategy. And this is the overview of my presentation. I will really start off with looking at where in South Africa are we in relation to the first 90. Then I will take you through some of the literature regarding the models of counseling and testing that could assist us to reach our first 90. And then end up by really indicating some of the policy gaps that are existing and which we need to make sure that they're closed in order for us to reach the first 90. Because we're talking about the 90-90-90, I thought I should start with this slide, which really says our first 90 is really identifying 90% of the people who are living with HIV and ensuring that they know their HIV status. As Romy has already indicated from the previous presentation, in South Africa, it's estimated that we have 6.4 million people who are living with HIV, and currently, of that 6.4, we have around 4 million people who are already on treatment, who know their HIV status. And so the gap, what you're seeing as a gap there between the blue bar and the red line really indicates the gap that we need to do in order to reach our first 90, the 90%. So we need to really be looking at 5.7 million people to know their HIV status who are living with HIV. This pie chart, really it's about looking at what has been done already, what are the gaps, and it says to us that the low-hanging fruits of people who are easy to test, we've already done that, it's gone. Now really we're talking about the high-hanging fruits, and this is the difficult part. So we really need to be knowing our epidemic and our response, and try to do the right things at the right place at the right time. Otherwise, if we continue doing the same things that we've been doing all these years, there might be a problem for us to reach, to attain the first 90. And most importantly, we need to use evidence-based approaches. Hence the reason why I'm taking you through the literature of what modalities have been tried and tested and what has been done in South Africa in order for us to reach the first 90. Before we go into the modalities, I thought it's important for me to pose a few questions in terms of South Africa reaching the first 90. One of the first questions is, which HCT modalities have the highest uptake? So which one is the most acceptable amongst which population group? We know that we want to reach more men, we want to get couples to learn their HIV status. And remember, the first 90, it's not everybody. We're really focusing on those who are infected, who don't know that they are living with HIV. The second question I thought of is, which HCT modalities produce the highest yield? And looking at the yield being those who are positive. So how do we ensure that we don't just test anybody, and mainly people who are willing to test are really those who know that they are low risk. So how do we access the high risk population so that they get to know their HIV status, and we identify those who are positive? And the list goes on. Which interventions enable the highest linkage? We need to, gone are the days when we're just testing, but every positive person that we identify, we want to ensure that we successfully link them into care. So regardless of the modality, where we are testing them, we want to ensure that we link them and they do get into the health facilities to access care. Another aspect that has been downplayed, but which looks like it's quite important, is mobilization. Because we need to adopt and adapt different mobilization techniques to reach these people. So which mobilization techniques, approaches should we use in order to reach our first 90? So I'll now go into the literature and the different modalities. This wheel is what we normally use within FPD. It really depicts an array of modalities that you will see for HIV counseling and testing, from non-fixed and fixed sites, within the health facilities, in the community. So it really just shows you different HCT modalities: provider-initiated counseling and testing, adapted, and now I'll present all these modalities. The voluntary HIV counseling and testing, index patient or index client trailing, also testing that happens in the private facilities. We have the non-medical sites that are providing and systematic home-based, as well as self-testing. I thought I should start off with the one model that really has been used a lot, or rather tried and tested, and there's a lot of evidence that it works and it might assist us to reach the first 90, and this is the systematic home-based or the door-to-door counseling and testing. As I've mentioned earlier, mobilization is key. So in this study that was done in Uganda and South Africa, they mobilized a lot. The mobilization started off with in the entry into the community. So you mobilize and go to the gatekeepers and negotiate with them. But once you've gained entry into the community, what is also important is recognizing that just entering the household as well, you need to get consent. So then the head of the house would also consent for the testers to enter the household. And once that is done, then the individual or couples testing would take place. And the people who are willing to test would still need or be required to provide their individual consent for the testing. So as you can see, there's quite a few levels of consent that they would go through. The gatekeepers at the community, the household, as well as the individual. And they followed it up with point of care CD4 referrals to the clinic for all those who tested positive. With this model that they did, as I mentioned, in Uganda, they had a 91%. In South Africa, they had a 91% coverage, testing coverage of the community. So amongst the community that they entered, 91%, they were able to cover that community. And they found a 30% prevalence. That's very high. So that's one of the signs that maybe when we go door to door systematically in the house, we will find the people who wouldn't normally go for testing, but are probably living with HIV. And the median CD4 was around 425. Still on the another study in Uganda and South Africa, they had 554 households where they tested 98% of the adults, and 32% of them were positive. And I think the good part is really the newly identified positive, which was 29%. So that was a really high rate. Other studies that have been done around door-to-door or systematic door-to-door would be this one in Uganda. Again, I think Uganda, Kenya, Zimbabwe are the countries that have done a lot, and South Africa have done a lot of studies around door-to-door, and where we should really be gathering data and evidence that this is a model that works. So Nuhawa in 2012, they also looked at the effect of home-based HIV counseling and testing, and they found out that it increased testing uptake. So uptake increased with door-to-door testing. Again, in another study, there was a 70% uptake of previously undiagnosed individuals. So those people who are not testing in the clinics, who are mobile, door-to-door, increases their uptake of testing. I think room for us for to increase our first 90 uptake. Lastly, I think I wanted to talk about the Dr. Van Rooyen from HSRC in the study that they did, and once again 91% uptake and 30% of the infected. So I think this just shows that door-to-door, systematic door-to-door model has room to play in achieving the first 90. So this is a summary of the systematic door-to-door that using home-based with the point-of-care CD4 and really using lay counselors or HCT counselors with follow-up visits, we're really able to demonstrate that acceptance is high and achieves high coverage. You cover a big area, adults accept it, as well as they're able to test a lot of couples. and find people with a higher CD4. So we are really able to find them at the early stages of their infection and link them into care. Another model that I think is important, which we need to talk about, is index patient model. This is HCT offered to household with persons known to HIV. So in the index patient, the initial point or end your negotiation is from the health facility using a client or a patient who's already on treatment. So that's your index patient. You negotiate with that patient, and they then provide you entry into their household to test the rest of the family members. So the index patient will then prepare the rest of the household for the testing visit, and then the testers come in. This model was tried and has been piloted by Ketimpilo, and we acknowledge Ketimpilo for this sites in a number of districts in South Africa, in a few health facilities, so where they used community testers to go into the health facilities and then go into the household. So it's a little bit different from the previous modality that I spoke about, from the systematic, in that you're not moving systematically from house to house. You're using the person who's already on treatment and going into their household. So it's a different, you're not moving systematically, but you're using, you might be jumping from house to house, but within a specific geographic area. Client's consent for HIV testing once you're in the household, and once the consent is obtained, then you go ahead with testing. I want to go through this slide with figures because it's actually summarized here. So Ketimpilo, with the pilot that they did, they found that for every one index client that they approached, 5 people were cancelled and tested. For every one person that they approached in the clinic who's infected. So I think, once again, a good indication. They had a 95% uptake, and 94% were successfully linked to care and treatment. I think the success of the linkage is that they already have a person who is on treatment in the health facility within the household. So linkage becomes quite easy for such. So once again, it's a model that I think has room within the first 90, for us to attain the first 90. Provider-initiated counseling and testing is one model that has really been talked about, discussed, and implemented in South Africa for a long time. This is routinely offering testing to clients or patients who come to the health facility as a standard component of care. They don't necessarily need to be presenting with, any signs and symptoms, but it's offered to anybody regardless of their condition. It's recommended for a variety of people, and this is what WHO recommends: STI, TB, ANC, key populations, and really anybody else. Great success in ANC in South Africa. We've seen that 98% of pregnant women who go to the health facilities in South Africa get tested for the first visit. However, there are some challenges with issues of patient waiting times or family planning, where people who come for family planning really just want to get the family planning service and move. So clinics have adapted services and made it a fast queue. Actually, when you go into health facilities, you'll hear that family planning is a fast queue. The woman just goes in, receives their family planning method, and they walk out. And they have not been given enough time to go through HIV counseling and testing. So these are some of the challenges that structurally we would need to look at. So quite a number of studies, once again, that have been done on provider-initiated counseling and testing, and in a number of countries. In Zambia, they found 40.8% before introduction of PICT. However, the uptake increased to 98.2% after the introduction of PICT in the health facility. And Leon et al. In South Africa and Cape Town also saw that 54.6% of new STI patients were tested for HIV with the introduction of provider-initiated counseling and testing. I want to talk about what we are now calling adapted PICT. The reality is that our healthcare providers don't have enough time to test every patient who comes into the health facility. So what should we be doing in order to ensure that a majority of patients who are coming to the health facility are tested? And McNaughton and her team, they did a study, and this was a multi-country study which took place in South Africa, Uganda, and Tanzania. And in this study, they were looking at 3 different methods of testing, but really what they came out with was that the method of adapted PICT, testing patients when they arrive at the clinic prior to them seeing the provider, it really seems to work out better and increase the uptake and more acceptable for the provider and the counselors and the patients in the health facility. So considerations for selecting and implementing provider-initiated counseling and testing: issues of efficiency and effectiveness in the clinic, much more efficient and does not disturb the patient flow. As I mentioned, provider and patient acceptability and satisfaction in relation to adapted PICT, and systems for quality assurance have to be taken into account, as well as linkages and care. One of the another modality that I want to talk about is mobile HIV counseling and testing. And in mobile HIV counseling and testing, really this is where we're taking the services out into the community, and ensuring that we make it accessible. I think of all the studies, one thing that we know about mobile testing is that, all the studies, what has been demonstrated is that it reaches more men, more acceptable for males and young people, youth. And so really, once again, for us to reach and attain our first 90 goal, I think mobile testing has room. However, with mobile testing, I think we need to ensure that we really tweak it a bit and avoid using just plugging mobile vans in shopping malls and testing the low-risk people, because they are the ones who would just voluntarily come to test. We want to make it accessible for vulnerable, high-risk clients. So we need to begin going into the informal settlements, begin going to these high-density areas where we know that there are some risky behaviors taking place. Go in there and make it easy for the population groups to test for HIV. So yes, mobile testing has really been proven to work in a number of areas and acceptable for men and young people. One of the contested ones is around self-testing, and the honest truth is, remember when I started, I said that we have low, now we're done with the low-hanging fruits. We're now really challenged to look for those high-hanging fruits. So with those high-hanging fruits, we need to broaden our minds, and there is room for self-testing. It's still something that we need to study further. A lot of studies have been done around acceptability, and yes, in some population groups it's acceptable. Healthcare workers, it has been piloted, healthcare providers, some key populations. But I guess in South Africa specifically, we need to fine-tune it and understand which population group, which target groups would be ideal to focus on self-testing. Self-testing as a screening, but not a diagnosis. So they just screen, and if the test says you're positive, then they would have to be linked for further diagnosis, where one would then follow the national algorithm and ascertain that this person is actually infected with HIV. So there are some different authors around the work that has been done around self-testing, and really the validity of the types of self-tests, which mainly is oral. It's oral testing that has been used, and it's been found to be accurate, acceptable, and I think, once again, room for us to find out who are the people who are suitable to use self-testing. Workplace testing, this is testing that is offered in a work setting, and really several studies have demonstrated high uptake, however, low identification of positive people. However, with that in mind, in South Africa, really we've seen a higher positivity in workplace around farm workers. So maybe this is a model that we want to adopt, especially when we know how mobile our farm workers are, and the issues of seasonal farm workers. So workplace has room, and we need to be looking at. So lastly, I just want to round up by looking at policy issues and some of the gaps that we need to look at. So really incorporating within our policy, currently the policy is silent around home-based testing and self-testing, and this is, I think, room with the first 90. This presents a really big opportunity to include home-based testing into the policy and allow providers to go in and provide home-based testing, whether it's a systematic home-based or it's using the index patient trailing model. Once again, I've already said that there is space for self-testing, and it shouldn't be locked out. I think also linkage to care. In most cases in the past, really HIV testing services would just focus on the testing. I think it's extended, that HIV testing services are extended to include linkage to care. So every person who is tested and is tested positive, in order for us to attain the first 90, the testing partners should ensure that they link that person successfully into care. And that can be done through the use of the point of care CD4 where possible. And really the approval that in some models, some modalities, the use of point of care CD4 would be useful. The last part is about quality assurance and ensuring that as we expand and broaden this HIV testing services, quality assurance and ensuring that we standardize the use of HCT registers in the country, as well as independent enrolling, ensure that everybody is enrolled on independent quality control and proficiency testing. Those are some of the key important issues that which should be addressed within the policy. So a summary of the models: compelling evidence on the mix of modalities, and we should move on and implement home-based, complementing it with mobile, or home-based systematic door-to-door, complementing it with the index patient trailing. High yield from index and client modalities. So we need to be going into that. Increased couples testing uptake from home-based and index. Also self-testing might be acceptable and need to be to identify the different target populations. We also need to improve linkage through the use of point-of-care CD4 and early identification of asymptomatic clients. Also, most importantly, we need to localize mobilization. Each modality should really have its own mobilization techniques. Just to round up with the same will that I started off, indicating the different modalities, and that all these different modalities really converge in as much as you're implementing them. Every time when you identify a positive person, the issue is ensuring that you link them into care. And ladies and gentlemen, that is the end of my presentation. Thank you.
Pretending that if we talk nicely to a patient in the facility, when you rock up at their home, their family is going to understand and are going to accept it, I think has been a bit naive. And to do it, I think we need to look at a complete package. A healthcare worker should be going into a home to do a number of things, not just HIV testing. So if we include it as part of a package of wobots, the neighbors aren't going to say, gee whiz, someone's visiting that home, someone's got HIV. So I think we have to be very careful around those issues. And then once mentioned in ethics, no one's mentioned opt-out. Isn't it time that we have opt-out testing at all facilities, even incentivize it? You opt out, you pay your 28 Rand fee to use the service, you accept the test, you don't pay your fee. We're facing a major problem, and I think it's things we need to look at. It's incentivizing, testing, and not punishing people who don't test. So I think we need to think out of the box.
Okay, thank you very much, Andrew. We were told by people from the department that opt-out was actually the official policy. So it's not a policy change, it's actually the need to implement the policy. I like the idea of the incentive being around the co-payment. That could be a really nice one. Okay.
I think one thing that I want to support that you mentioned, Gustav, is the issue of putting counselors in the facilities. I think that all the efforts we could do with home testing, because there would be challenges with linkages into care, but if we focus on testing at the facilities, I think we would yield more results than other modalities as far as I'm concerned. So putting more counselors in the facilities would actually increase the numbers of people that are tested, because people are there at the facilities rather than us going find them there in the communities.
I think one of the things we need to look at, though, I mean, we feel we've got a big drop-off in terms of the number of people who get tested and those that we know are tested. I think we have to do some focal studies, maybe at district level, to see what are the reasons for our data losses. Once we find some of those, then I think there'll be an incentive, certainly, to try and invest in addressing those. And I think in other areas like TB, we've certainly found that that has helped find where the losses are, and then you can address it. So I think we need to do that for HIV too.
Thanks, Timber. I think it's a big thing that it's come out on the work of the think tanks as well, is that there's often areas where we actually do not know the reason. So why is there this high drop-off of people once they're on treatment? And I think, again, that should be part of our strategy, to start saying, you know what, there's areas that we haven't got a clue, and we need to get some research going. I think it's the same as what James said, is there is probably a need to have research around the self-testing. Although I personally like the idea of using test kits like condoms. You sort of flood the market and see what happens. All right, Romy.
Sorry, Gustav, and I am an M&E person, so bear that in mind. I think that the thing is that a lot of the interventions we're looking at, if we're talking about in-facility interventions, it doesn't change the fact that actually the people who access the facilities are accessing the facilities when actually they're already eligible for treatment in terms of the 500. So I actually agree with Professor Venter that actually we need to be looking at how we identify people far earlier than what they are being identified today. The issue that we're sitting with is that they're not accessing the facilities, they're not coming in. So we need to look at community-based interventions to actually identify people in the community. That's how we're going to reach the first 90, I think. No, I'm not suggesting, I'm just saying we need to look in the community. I think that the thing is that if you look at the people that are actually accessing the facilities, we are testing them, yes, not enough, there is a gap there. But the majority of people that we're actually not identifying are not even accessing Department of Health facilities. So I think that things like the index patient testing, identifying a positive patient and then taking them back into the community and testing people who actually live with them and are interacting with them, I think that's actually one of the modalities that is showing the biggest yield. And I think that's something that we should be looking at.
So if I could just ask people, when you talk, perhaps not so much of we should be, but perhaps also linked to that, the how, especially if you've got experience in your organization.
Yeah, thanks.
Go fire away.
Yeah, well, you know what, I tend to think that supporting household testing and self-testing would be the best option. You know, because most of the facilities are experiencing, well, talking from the DKK point of view, that we're experiencing lesser and lesser headcounts in facilities versus other implementable policy decisions, such as the ICDM, for instance. We are definitely reducing the number of patient visits to facilities, and you know, having people being available at facilities for testing, that would definitely be affected through those reduction in utilization rates of our facilities. And secondly, it's infrastructure, you know, challenges in most of the facilities. Yes, you might have a lot of counselors, for instance, in facilities, but do they have enough space for them to do counseling and testing? And we know, you know, for the fact that from the 3x4 matrix assessments, most of the challenges reflects to both HR and infrastructure. And household testing might relieve that, because once we confirm, you know, policy for testing and allowing our robots to do those household testing, because they are there all the time, and they can have enough access and yield, you know, out there than, you know, concentrating in facility-based testing.
Thank you. I think coming in towards the end, it's quite easy because a lot of people have said what they want to say. And for me, I don't think it's a magic bullet. It's going to be a combination of things. If we are looking at picking up patients in facilities, especially in your hospitals, I think we need to be doing the treatment and the initiation there and then in the ward, because we're losing patients when they're referred to a wellness clinic. We're losing patients when they are referred to a PHC facility. We also have all the patients on registers that are positive, but pre-treatment, we lose those patients. Those we can pick up with point of care in your home-based testing, but we need to know why that's not acceptable. Because it doesn't help if our robots and everybody go out, we do point of care testing, we refer a client to a facility, and the facility doesn't acknowledge the validity of the test. And then they're wanting to retest, and your patient goes away. And that's where we find we're losing people on the ground as well. So we need to find a way to say, if you're doing all this mobile testing, if we're doing home-based testing, if we're doing self-testing, the clinics need to acknowledge the results. Otherwise, we're going to be testing and retesting and still not getting anywhere.
Thank you.
There you go.
She touched on an area that I was worried about. A captive audiences, missed opportunities, hospital volumes that go through. I'm not sure that we've tightened enough there. And I think it's an area we could look at very powerfully. The outpatients of all levels of hospitals, and then to think about the concept of missed opportunities right through and introduce that as an area that we work with powerfully.
I like that. I think it picks up with the idea again about the counsellors. If you want to use the high volume sites, you need to have the people in those facilities that can respond to it. I think the comment was very valid about about making sure there's infrastructure in those facilities where tests can be done.
I just think we're not really thinking very innovatively about self-testing or community-based testing. I think there are ways we can quality assure them, not by distributing material for them to check, but we're working with groups and some engineers on taking the assay, being able to put it back into a smartphone, providing a link to a call center, plus a link to where you can get the care. That's the one aspect. And then the last aspect, which I will talk about in my talk this afternoon, is the dirty word in health, incentivization. And I think they call it compensation. But I'll show you with mobile money banking options how we can possibly use the community better as our HR resource, pay them, but have very clear GIS-linked the Uber of health. So we'll talk, I'll mention that in my discussion later, but I don't think the quality issues or the use of the community are insurmountable. It's just how we do it.
So because these mobile apps and things tend to talk towards linkages to care, we're going to cover that in the second session. So if you'll just hold back on it, because I'm sure you're all building an app. Professor Barron, where have you disappeared? Pete, do you want to, no, hang on. You're going to speak now. I have to get him to read a poem now about the wobots. Do you still remember your poem? You want to give the do you want to talk about the wobots? No. I do think Peter's got a point, is we just need to, although they can be a very strategic resource, we've got to be careful about what we are dumping on the wobots. Because I remember years and years ago when I was in Geneva, we all got very excited about the first incarnation, community health workers, and I was asked to get all the training programs at WHO for community health workers. And this was the days before the internet, etc. So we had to send it with a diplomatic bag. And just going through the different departments at WHO, I ended up with a meter-high pile of training material that theoretically people had to assimilate in 3 months. So I think there's a bit of realism there. James.
That part of what we're missing in the graphs that we've seen is who the gap is. And we can put all of this effort into opt-out testing in facilities and counsellors in facilities. We're still going to get predominantly women. And unless we have strategies that are going to get the missing men, we need to understand who the missing men are in general, I think, in that cascade, and then think about what the strategies are that target that. Because I suspect that we're getting the 90% of women yield, but where our gap is in fact very often in men.
So Gustav asked me to speak about the WBOTs. I think that what we're trying to do here with HIV is something exceptional. We're not trying to strengthen the whole health system. If we try and eat the whole elephant at the same time, we will get indigestion. So I think that HIV for me is still somewhat of a vertical program and is a crisis for South Africa. And we need to look at all the ways of trying to get people to know their status. So I agree with Wendy Stevens that we need to be innovative and try and get those people who are not coming to facilities. And it's not only men, James, it's young adolescent black girls in townships as well who are not coming in time to get their HIV treated before they fall pregnant. So I think that using technology, using franchise people, paying people incentives for getting people tested and at the same time getting circumcised and getting them into care is a good thing. I think that where the Department of Health doesn't like incentives is paying health workers. The slogan that my boss says is you don't pay fish to swim.
Okay, so let's just check somebody here. Is there anybody who is currently amongst the PEPFAR partners using incentives? No one. Okay. Can we hear if people got incentives that was approved by USAID, can we perhaps hear what those incentives, okay, because I think part of it is should we be putting this into our conversation with USAID and say, you know what, we need to start looking at incentives, whether it's airtime. We do on the First Things First program that tests at universities, we were allowed to buy memory sticks. It came sort of in a bracelet thing, and that was a big incentive for getting students to test.
I can say that we have protocols designed already, and we submitted one to the Gates Foundation a couple of months ago, and it made the top 2.4%. So globally, it's becoming a big interest, and people do want to fund this type of work.
Can we suggest that we start looking at having this conversation with USAID? All right. Anybody else at this point who's got a burning issue to? Yes.
I think that one issue that we are not mentioning here is that although these targets are for 2020 in terms of PEPFAR, they want us to reach them in 2017. September, I think that some of the suggestions we might not have time to implement if we still have to look at policy reviews and policy or develop policy on certain issues. I'm not sure whether we'll have time by September 27 to implement those things.
So, you know, we're the private sector, we're supposed to move faster. I do accept that what we're discussing here is not about changing government policy, it's about what do we implement. Right, so even policy, if it lags a bit behind, nothing I think prevents us from implementing. We are under relatively high pressure to get stuff done. Right, so the other thing.
So Gustav, you're quick to take on the mantra of going towards incentives. I mean, I personally think that has value, but I think that we've got the analogy that you don't pay fish to swim, so it seems that healthcare workers are out of it. But there are going to be issues that maybe this group wants to discuss. Is it the franchise owner who's the person who's incentivized? Is it the healthy or unhealthy individual who comes for the test who's incentivized? I'm pretty sure that there may be some need to discuss standardization of what is the magnitude of the incentive. Is it a disproportionate incentive, etc.? So I think that if we're going to do that, we would have to log the fact that even in discussing it with funders, we would have to discuss the various variables and have some clarity on what we were comfortable about in terms of standardization and who the incentive was offered to.
So perhaps just a clarification for those of you who have not been part of the discussions around the franchise. The idea around the franchise, micro-franchise model is a PEPFAR partner sets up a micro-franchise. You get people from the community who get paid on some system. We don't know what the system is or what the the amounts are to go and test people, and then they get a bigger, if they test somebody positive and they manage to get the person into treatment, they get paid another amount. And the idea really is to test with these things to see how market forces work. The sort of what triggered that debate was the experience in Kenya around the M-Pesa franchises, where they've got 60,000 M-Pesa franchisees that's busy out there making it work. In South Africa, we've tried to launch that franchise a few times using fixed facilities. So they try to roll it out through banks, and it doesn't really work. So I don't think that that's not the same as incentivizing healthcare workers, because this is how the people generate the income. They're in the private sector, they're not part of the public sector. I would guess if we're talking about incentivizing patients, it would be around either using something like airtime that you can incentivize people to get them from testing through to to treatment, or it would be by the government saying, right, certain fees get dropped if you do. I like that suggestion. Do we want to have further discussion on the idea, Themba?
Thanks, Gustav. I've had some experience with incentives, not here, but in Botswana, where basically in a male circumcision program, the incentives were given to the mobilizers, or people who are bringing people for treatment. And I think for me, there were lots of ethical issues we had to make sure that our funder was happy about and government was happy about in terms of how we did that. But I think in terms of incentives for in a care situation, I think I'd be very careful if it looked like incentives that you might be providing might then be linked to additional fees that patients who are not getting tested might then need to pay. Because I think then the question becomes, is this a way in which you are actually impacting on access to treatment? And I think you'd have a lot of ethical issues to discuss there. So I think that's where we'd need to be cautious.
So I would argue it's the opposite. If you take away a fee as an incentive, so if a person doesn't have to pay the X amount, you would argue that it opens it up for, you'd facilitate access, and you're creating a very powerful incentive for a person to save money. The question really would be there whether government can, what's the impact on the government finances if they suddenly lose user fees? We saw some interesting things around when user fees were dropped for patients on treatment in government facilities. It meant that the patients did not have to go and join the queues in the morning to go and pay their fee in their file. And we thought this is a great opportunity for improving quality, because we would go and draw the files the day before. Within a few months, those patients were back in the queues because the admission clerks were extracting bribes out of patients to find their file. And they would then go and basically sabotage your intervention. So it is a complex area, but I do think, and what I would suggest, certainly our experience around talking to USID about the franchise model, there's been a similar conversation about testing models of putting patients on treatment again using private practices. There is a willingness in USID to allow you to put pilot projects together and monitor and evaluate them. So I think we won't have the definitive answers here, but if we do come up, I think, with something that's interesting, as a PEPFAR partner, go and speak to your agreements officer's representative and see if you can build it into your plan. The big thing just is evaluate the pilot programs and share the information as fast as possible. I just don't think we don't have the time horizons anymore on our grants to say we're going to pilot something for the next 2-3 years, then go and write it up for a journal, and that takes another year, etc. So there's got to be some system of rapidly moving on these things. And we can, I think it's easy enough for us to convene as groups like this every now and then if it's necessary to say, right, it's 6 months later, what have we learned in the process? Right, anybody else at this point that, Suzanne?
Hi, I wanted to actually make two comments. One, at the very beginning you mentioned the low yield of the mobile units. And I think one thing from FPD's experience with the mobile units is the percentage yield is relatively low, but the absolute yield can be quite significant. And another thing that we're identifying with our mobile units is a sizable proportion of the HIV positives after the test acknowledge that they've tested positive before. So there's also an interesting thing happening here with the mobile units, finding the people who already know they're HIV positive who haven't linked to care and performing a role to linkage in. So I think that's an interesting thing for us to think about the role of mobile units for that population. And then the other one about the self-testing, I think there's great opportunities for self-testing with the antenatal program. For the woman who is negative, to take it home to her spouse if the spouse cannot come and access the couples testing. For the woman who is positive, seeing if there isn't the opportunity to take the tests home for their children, some sort of screening mechanism in the community.
I just had this vision of you come home and you sit down for supper and there's a test kit on your plate.
Thanks. Okay, good morning. TB HIV Care is supporting the Department of Correctional Services, and I know this is a very small population, but obviously a key population. My mind is just working around incentives. Obviously, the adapted PICT is the way to go, you know, in this area, but I'm looking at incentives. We often battle to test the inmates because the security department will not give us access to the patients. Could we not incentivize the security to let us have access? Because then that would actually solve one of our problems. Thank you.
You get released 1 month earlier if you come for an AIDS test. How difficult is that incentive? Remember, it's about doing things different. If we do things the same way, it ain't going to work. Right, I got swamped now with hands. Andrew, you haven't had a chance yet? It wasn't you, were just scratching your head. Okay, so Wendy.
Okay. I would just like to say that one of the best looked after group at the moment is the correctional services. So we don't need to incentivize anybody there. What we do need to do is when they leave the facility, manage to link them to care. So I think they're getting a pretty good deal in terms of HIV, rapid testing, in terms of TB screening. We don't have enough infection control, but their biggest problem is where do they go upon, how do we refer them back into the system once they leave?
Thanks again. The one thing we haven't mentioned yet is the point of care CD4 testing, which you wanted to cover. I personally don't see how that's going to increase testing or linkage. Regardless of your CD4 count, you need to be linked to care. And I think not having it is actually a good opportunity, because if we're doing these home-based tests, when a person goes to a facility, they'll have a CD4 count done and can have a ELISA done on the same specimen, so you've actually got good confirmation rather than false positives. So I think we shouldn't get lost in technology, which is nice and may be good, if it's not actually going to add anything to the program.
Can I check, is there anybody here that strongly believes about point of care CD4 testing? Except Tato. And Wendy, you want to respond to it?
So I don't strongly believe we can do it nationally from a cost point of view, but where we can do it is where we have gaps. I mean, if you go to the Northern Cape, it can take us 8 hours to drive a CD4 down to somewhere. I think within a tiered laboratory model, there definitely is place for CD4. Within correctional services, maybe on mobile vehicles, but to do a total coverage of the national program, we're talking 4 million CD4s currently. I suspect they may go down because of guidelines, but, you know, it's money.
I've got a feeling the CD4s are starting to morph into the same thing as a mobile testing unit. It's something that you have to strategically deploy where it makes sense, but it can't be part of every mobile unit needs a CD4, every clinic needs a point of care CD4.
So just on the point of care CD4, Orum's just completed a randomized control trial of TB index patients and their contacts. And Tata, you pointed out that there's not a lot of data on that. Our randomized control trial unfortunately also showed a very low uptake of HIV testing in the household, so 37%, which is as opposed to HIV positive index patients. However, we did do point of care CD4 in the household, and very interestingly, it seemed to actually increase the chance that people would take up the HIV testing offer in the household. So it seemed to be encouraging to the patients to think, oh, if I know my CD4, I'll do an HIV test. Unfortunately, it didn't increase linkage to care.
So I just wanted to note 2 points. One around household testing, that in one of our projects focusing on ward-based outreach teams, the common finding is that even when the outreach workers go to the households, the men are not there. So that's something to consider as well. I think the other thing is, I think James highlighted, is we haven't done some very rigorous social profiling and psychographics, say, where are these men and what are the places that are being found? Could we have a scenario where probably we want to incentivize tavern owners to do the testing and, you know, take it out of the box really, because where are men meeting and what are those safe places that they meet, that's where we can test them and get a high yield. So that's something to think of.
So that's the idea. The idea behind the micro-franchise is exactly that, is that the micro-franchisee can then be the tavern owner. And they get paid for getting people tested and get them through to treatment. So that will give us the flexibility to test those models. The other question I think that we haven't talked about is that you've sort of touched on this thing that people don't really live in clinics and facilities. But the other thing is lots of people do not have the time to sit around and spend a whole day at a facility to get a test. So my question is, do we have enough other alternative options out there for people who can't access facilities during office hours? We had an interesting survey around the Tutusela care centers, which is the rape support centers, and the biggest criticism coming from the community is rape actually doesn't take place during office hours. And there's a complete disconnect between the hours that the services are available. So I don't know if there's any discussion about making services available after hours, early hours, things like that, and if anybody's got experience with that. Should we be testing that? Should we be testing models where would we get a better yield with our mobile units if we park them from 6 to 8 in the morning and from 4 to 5 in the afternoon at railway stations? I think that's worthwhile trying and seeing if that improves our yield on those things.
I think it's definitely the point, because I think that's potentially where we fall short with home-based testing as well. If you're going there during the week in the middle of the day, who are you actually going to find? Husbands are working, or the men are working, they only get to a hospital or a clinic when they're really, really sick, which is why we're not finding them. Children might be at school, so it then impacts as well in terms of where do we get the drug delivery. Surely we should be going where we're going to find the people, whether it's at a taxi rank, whether it's at a train station, but then if we're doing the testing there, those results have to be ratified if we're linking to care, and then maybe we have to have drug collection points where it's accessible as well, and you can do your viral load testing, etc. at the same time.
So I think people should be trying models around this. Who can? Sorry.
I just want to put this out, especially thinking about the mixed opportunities, the mixed.
Project your voice.
Okay. Talking about the missed opportunities, I would like to say there is this population of people, and since this is a brainstorming session, and being from the Department of Health and looking at the people that are actually accessing our health services, there is a group of visitors that come to health services around visiting hours. And if you go to Bara, one of our main hospitals, Bara or Joburg Gen, or even the one in Pretoria, you will find a lot of people that are just coming to visit. And because they are within a hospital, I'm thinking that is where the mobile clinics can actually target these. And I would like to find out if this target group, are we looking at it? Because I even visited a few relatives I know, they are coming with some concern and they might test. And they are men and women and people of all age groups. And they're just sitting there waiting for the door to open. And when it does for that hour, that might be an opportunity to actually test a population that we are missing, especially in urban areas and high-yield areas like Gauteng.
Has anybody experimented with that? Margaret, did you experiment with it? Okay. I taught you about... Right, Jackie.
Hi. Thanks. We didn't experiment with that. We have an intervention in the Northwest at the moment, which, with regards to couples testing and it's home-based testing, with the female, the woman antenatal patient being the index, and then taking the testing to the home. So this has required the Department of Health to give us permission for the community health workers to actually be trained and to do the testing. But what we are finding is the biggest uptake is on a Saturday and late afternoon, early evening during the week. So it's created quite a lot of, it's created the need for a lot of innovation and for a mind shift from, for example, the community health workers' point of view, that in fact they might not be working from 7 to 4, that they actually might be working from 11 to 8. And so it's still in its very early days, but the uptake is picking up. As soon as the services were offered on a Saturday and in the evening, so the uptake has started to pick up. So we're looking forward to some more results from that, but I think it's certainly one of the options we've been talking about this morning.
So based on what's being said here, and given that we're more flexible as PEPFAR partners than the public sector, I'm starting to wonder if we should have any community-based activities that operate during office hours. Shouldn't that be where we're moving to say we have to have, our staff just don't work normal office hours. They start at noon and they finish at 8 o'clock at night, and there's another shift that starts at 4. Unless we can...
This is a country with 20 to 40% unemployment, some of these target groups who are around.
Yeah, but they've probably been tested to death by now. In the 2008, when there was xenophobic attacks happened, and there was these sort of refugee camps almost set up outside. We went to the one outside of Tshwane. And there was 1,800 incredibly bored people. So the moment we parked the mobile unit, everybody just queued up. They all came for a test. I think we found one HIV positive person amongst them all. When we parked the unit a week later, they just to come and drop some food off. They all stand and came and queued up again. They were just so bloody bored. It was entertainment. And I do think there's a component of testing, which is because you're bored. You get to talk to some interesting people, they show some compassion, they talk to you, but I don't think people go there. So I expect, James, I won't say that all our staff should only, but I think, again, it becomes strategic. You need to probably have a justification why you have a mobile unit operating only office hours. And if we did this, if we made this change, we're going to have a lot of staff that ain't happy. But we might actually make a difference with this period we still have PEPFAR funds.
I just want to add one thing from experience around mobile testing is people that are testing is people that know their status. So we haven't touched on stigma and we haven't touched on mobilization. So I think that is the key to get testing is available anyway. You can walk into a pharmacy, you can test. People are not testing because of the stigma associated to that. And mobiles are strategically placed in areas where people are known in those areas.
Loud voice. 6 mobiles that do just testing, so counselling, CD4 and Gene Expert. They're incredibly expensive to build. We have a design which I think will stand the test of time, but it costs 3.5 million rand to kit out a vehicle. The pickup rate is fairly low, and to keep a driver and a nurse driving I don't know how many kilometers a day actually costs a fortune. Then you also have to look at consistent power supply, getting the results back in the right format, and basically for us a lot of the value is just public relations more than anything else. It's a very expensive exercise for us.
I just want to get back to the policy issue with birth PCR testing. At this stage, I think that can only be done by nurses. And we haven't touched on that. That's a new initiative. We know there's a need in the labour wards to actually support by either counsellors, but if they can't do the testing, then it's going to be very limited. So I don't know if we've addressed that. Then just on the mobiles, we found in NICE now that we reached a lot of young males that were unemployed by having the mobiles go into the informal settlements and in those communities.
Okay, so remember we said we have 2.5 years left to implement this project. So policy changes, hopefully Peter is taking note of it, they'll take it further. We try and operate as much as possible without breaking any laws or anything like that. I do think you're getting sort of consensus about mobile units. They're expensive and they clearly have to be used extremely strategically. And I would question if any of us keep on going with the old model, because in the old days, let's be honest, the incentive was the number of people tested. There was no incentive to get high yield, there was no incentive to test men or anything like that. You just had the mobiles out there, you gave them a target, and they tested people over and over and over again. And I do think as the funding is running out, so what we have consensus here is that we're going to start using them strategically, and I think any partner that in future just has a mobile unit that meanders around during office hours trying to find people, there should be serious questions asked. Right.
Thank you very much. I think that one of the assumptions that we tend to make is that when we do target and find people living with HIV, that they would want to know the status. And I think for me, South Africa also has a burden of a habit of non-communicable diseases. For me, so how do you package a service so that it is attractive to people? So when you get there, you basically kill 2 birds with the same stone. You could go in there, you could do blood pressure screening, you could do cholesterol screening, and then offer HIV test as one of the things in that package, and maybe make it more attractive for people to want to test.
So last time I looked, we could not use PEPFAR money to test for cholesterol and diabetes. Has anything changed? Nope, hasn't changed, still the same rules, etc. So I guess if we want Peter to go back and talk to the government around policy, we probably need to have a chat with PEPFAR around policy. But I do think the point is well taken. I know we're completely ignoring this thing around stigma, right? Because I guess we're a bunch of implementers here, and we don't have any social scientists often running around in our environment. So this whole thing about social mobilization, stigma, etc. I know there's a task team under the think tank for scaling up treatment that's supposed to be working on it and come back with some support. is there anybody who wants to pick up on that subject? We've got about 15 minutes left. So I would, if there isn't any big new burning issues, and the only issue as far as I know that we've completely haven't picked up is this thing around mobilization.
I hear what you're saying about partners having mobiles traveling around, they should be after hours and so on. But in fact, I mean, PEPFAR is shifting hugely from direct service delivery, and in essence what those mobiles are doing is direct service delivery. How as support partners do we engage with the Department of Health at a district, at a provincial level, even at a national level, Peter, to reorganize their services to take this up? Because once PEPFAR funding is gone, so is that mobile, and so are the 90% testing.
So that's, I think, why we need to catch everybody we can as quick as possible while we still have this. Our experience has been terrible in terms of trying to transfer mobile units into the public sector. As a rule, it just doesn't work. The planning isn't there, the staff aren't there, the budget provisions aren't there, and I don't know if anybody else, if somebody's hacked that thing. What I do know is that 2.5 years from now, there's going to be a hell of a lot of vehicles that are suddenly going to be looking for houses. But the first things first, people at AIDS, at higher education aids, Ramnik is happy to take any mobile unit that you've got standing around. Okay, there was somebody nudged me to come back here. I was ignoring, I knew I was ignoring. Sibongile, I'm sorry.
No, on the mobilization side, because we are health system strengthening partners, there's work that we could be doing on the AIDS councils, because we are, after all, supposed to have a multi-sectoral response to HIV and AIDS, and testing is part of the package. So we could be focusing on the AIDS councils at district, local, and at the ward level. That is an area that we have not actually looked at for sustainability and for ownership of these programs we're supporting.
So I agree with you. USID doesn't and PEPFAR doesn't agree with you. One of the areas they've said we have to de-emphasize our work is around management and governance structures, and that's what AIDS councils are. All right, we're going into the last 15 minutes. Who is the rapporteur on this session?
So I'd like to turn the conversation towards the measurement side of it. And maybe it's just because I haven't worked in this particular space, the community space, that much, but how standardized are the measurement tools around the community testing? I mean, sure, we know how many people are tested, how many are positive, et cetera, but in terms of the other processes and the specifics around how it's done, you know, are we measuring that properly? And if we are, is there a standardized tool that is being used by everybody, or is it kind of every partner is using their own format?
Okay, it's a very specific question. Tatu, Romy, you sounded like an M&E person. I'll give you another M&E person.
Just in terms of how the community-based testing should be done, so there's a few ways. You can actually create, whether it's a mobile unit or a community-based organization, you can create it within the DHIS. And therefore the numbers reported actually go through the Department of Health system and get aggregated at the national level. The best data collection tool at this point to use is probably the HCT register, which is the tool that I think most partners use, and also that is used in Department of Health. So you can use the... Oh, so information outside of the HCT register. I think everyone is kind of doing their own sort of little mapping exercises and things like that.
I'm going to ignore you for a while because there were two hands up here, but I'll have to talk faster. Right, Andrew, back to you.
Hi, thanks. So around mobilization, I think we need to start drawing in other sectors and stigma, because we seem to have failed at that. We've got a national broadcaster. I think it's time that we start putting pressure on the national broadcasters that on 7 de Laan people are being tested, and not just tested once and sometimes been found negative, that people go through the problems in these programs that our patients do. And I think it's really time that we start putting pressure on other sectors to address that, because as a health sector, I think we failed.
So I just need to correct this. If the impression is that the national broadcaster has not given this thought, please remember their chief operating officer recently said if you report on crime, crime goes up. That's why they don't cover AIDS, because they don't want to contribute. But I do think it's a very valid point, because we were Seoul City did a project on gender-based violence. They had a whole season dedicated to addressing gender-based violence and about what the Tutuzela care centers are and how you access them. And that I think is something really important. And actually, if somebody can find coherent management at the SABC, perhaps we should engage with them. Clearly, I will be inspected on my TV license.
Sorry, just one of the things that I don't know if it was mentioned, but part of the ACT strategies, my question is, how do you rope in the private health sector to be a part of 90-90-90? For example, how do you get how do you incentivize general practitioners to test more people and link them to care? I think that's one of the gaps that we also need to address.
Thanks, Gloria. There is 3 or 4 pilot projects around this exactly that's being done, and I'm pretty sure Francois is probably going to pick up on that on the second 90. Right now, wait, hang on, I bypassed you.
Thanks, Gustav. I think I'm just going to go back to what Craig mentioned, because we're both from the QI school of thought. And the issue about measurement is that when we do our HCT work, we find that there's a lot of gaps between the reporting part of it from the NGO side and also from the DOH, where you find that NGOs are actually, they're obliged to actually still hand in their stats to the funders. But in another way, there's also like double recording that happens, and they sort of like bypass that. So we find that there's a lot of numbers that are actually not fitting into the DHIS as expected. So for us to actually do proper quality improvement, it should be based on proper management of our M&E, which we find that, our stats are really not telling us that we're actually getting all the numbers that we should be looking at. So it becomes sort of like a challenge, and maybe that's a question I would pose to the M&E to try and look at how do we make sure that both systems from the NGO side and from the department are actually linked to make sure that we get concrete numbers.
Just a comment there. One of the biggest problems we see, even just within the public sector stuff, is, for example, there's districts which don't have budgets for data captures. But there is this leapfrogging opportunity, because more and more systems and affordable systems are coming out where the providers just catch basic data on mobile phones. So you're actually disintermediating the need for data captures. And I think there's a big opportunity around that type of mobile phone data collection app stuff. And I know that National Department is starting to become enthusiastic about apps, because that way you can have data flowing, whether it's from NGOs, etc. There's a big issue around this thing. It's the unique identifier. And it's, again, one of these things that the policy says it's the ID numbers. I know there's a problem, and there is some solution about people who don't have ID numbers. But again, it doesn't get, no one is using those numbers. But I think the point is taken that we all have M&E people, we've all got people who work on data quality, and that needs to run parallel. It's the old thing, if you can't measure something, you can't manage it. Tim, and then Francois.
So I think it's very encouraging that we all are ramping up to try and achieve the 90-90-90. But one of the things we do know is that HCT is done very poorly procedurally within the country. So I think that one of the things we may need to want to do is link to Adrian Piren's work looking at internal and external quality assurance to make sure that all the implementing partners have a linkage to that, and that we can assure that the tests that we are doing in the field are actually quality assured. We know that it's done very poorly in the country, and we have an opportunity to improve that.
Okay, not debatable, just reality. Make sure you quality assure your stuff.
So I didn't hear earlier that there was a comment about the workplace, but two of the groups, I think, Gustav, who've had a really easy ride is the private sector. And I really do think there's an advocacy role here to say to large workplaces, test 90% of your workers. We don't care how you get there, whether they hire FPD or they take on a PEPFAR partner, or how they get there, but they actually need to get 90% of their workforce tested in an ethical environment. The second group who's had a completely easy ride is the government. is they are, in many of the provinces, the largest employer, and they haven't got to 90%. And it's all very well to make this Department of Health's problem, but everybody else, I just think, should be given this 90% target in the workforce to make sure they get tested. As I said, how they get there, there's Indaba. But come World AIDS Day, no more lighting candles and chanting and all the rest of it. Get out there and test your workforce.
So I'm going to comment on the private sector, guys. Peter, this is a to-do for you. If you want the private sector to test all the employees, find a way of linking it into the new BBBEE codes. Right, these new codes are incredibly onerous. Those of you who haven't looked at it, it's the equivalent of an additional 10% corporate tax that's being imposed on companies. And that means they're all going to become incredibly resistant to spending money on anything else because they're being forced to spend, just for FPD to be compliant, we've got to spend 8 million rands a year that we weren't spending at the moment. So it's an enormous amount of pressure coming through on companies. You will never sell anything new for them to do for the employees. But if you link it into the BBBEE codes, if you say this is a way of your employee development program is 90% testing, I can also assure you before April next year, 90% of all people working in any company that needs to get a BBBEE certificate will be tested. So again, I think it's a matter here but this can only be done at a policy level. But I think it's a great suggestion, Francois. Right, we are coming to the end of our session. I need somebody to entertain us for another 5 minutes. Is there anybody who would like to volunteer? Yes, there is always somebody who will be the last person speaking. Josh?
Josh with Innova. You said entertain, and I thought I would try my best. I'm an M&E person, so just another tool that we have on the ground. It's facility-based, so it's not community-based, so it's not ideal. But I think there's a certain urgency to get all HCT in an electronic format. The HCT registers are paper-based, and it's going to be, we talk about linking to care later. If it's not in a digital format, it's going to prove challenging to monitor in the continuum of care. So just there's the tier.net HCT module. To Craig's question, how would you work that into community-based testing? It would be quite difficult, but that's a tool that's in the majority of the public sector facilities that could be used. Of course, you're going to need another data capture or a person who has the time to enter it, but it's just something that's out there now.
It's not often that you hear somebody use the word entertain and M&E in the same sentence. I mean, that was really well done. I would argue that it is time for us to move the M&E off data capturing platforms where you need dedicated data captures. You need to collect less data instead of more, and it should be this app device driven type. We're all doing it. Any of you who rate a restaurant on social media, you're busy doing M&E, quality assurance, data capturing. And there's a lot of fascinating, I don't know if those of you who rate on TripAdvisor will have noticed, if you've done a few ratings, you get a little badge, they nudge you, they tell you how many people have looked at your data and what they do. I mean, that's where the world's going, and we're still thinking about clunky, computer-based, let's train data capturers, and then the budgets don't support them. So again, I think it's worthwhile for people to try some innovative new things around that. Anybody who really wants to have the last word? Okay, then I am going to wrap up the session. There's tea outside. I've got no idea how long for tea. 15 minutes for tea. Thank you very much for your participation so far. I think there were some really good new ideas that were shared that we haven't heard before. And I think that's the purpose of this thing. And I do think when the rapporteurs pull it together, we'll try and give you the consensus. And from our side, we're committing that the rapporteur report will be out by? Monday. Right, so we're going to send you the report by Monday. We will share it with USID and CDC. Is there any USID or CDC people here? Okay, so who of you made the threats against them or something like that? we will share it with USAID and CDC, because I do think there's some questions around their policies and practice that we need to push them to also address. Okay, thank you very much, everybody. We'll now break for tea for 15 minutes. We reconvene 11:45.